Wissick. I am with the South Carolina Collaborative for Fetal Alcohol Spectrum Disorder, and I am here to talk about implications for practice for fetal alcohol spectrum disorder problems and interventions. And I apologize, but my computer totally went into a la-la land today. And I'm, switching back and forth here as usual. But so I'm doing this from the PDF version, which you will be able to get a copy of when after you watch this. But after you're finished, you can discuss 2 facts and 2 misconceptions associated with FASD. Describe the characteristics of individuals with probable exposure, and my nose itches. List 4 strategies to assist an individual with fetal alcohol, and identify at least 2 web resources for early intervention or to support during pregnancy. So we'll think about this as a new, this is a new PowerPoint feature. It's called Flip, flip from one to the next. Okay, so I'm part of the collaborative. I'm retired faculty from the University of South Carolina, where I taught courses in special education. I adopted 2 boys from Russia in 1994. And, they were healthy. They were pretty healthy. It wasn't until later, and because I was a trained special educator, we used lots of kinds of things that help, but it wasn't until I got to school when we really started having lots of problems. So as my sons got older, I became involved, and I went to see and listen to Dan Dubosky. And I found out about a group that was a collaborative out of Deotis, and from then I've been on this journey for about 15 years. So the mission of the collaborative is to provide information, education, training, to help reduce pregnancies where there is prenatal alcohol involved. So what's the definition? Well, it's not a diagnostic category, and so I can't say, oh, you have an FASD. It's an umbrella term that it talks about the effects that occur if a mother drank alcohol during pregnancy. So drinking alcohol during pregnancy results in a number of issues. There's physical, neurological, mental conditions, behavioral. It also creates long-term problems more than any other substance, like a lifetime worth. It's 100% preventable, and it's 0% curable. Now, here's some common misconceptions. All persons with fetal alcohol spectrum disorders can be identified by facial features, and that with Anne. All persons with an FASD have a low IQ, and the behavior is willful and purposeful. Well, I don't know anyone who wears glasses and says, it was my choice to have vision problems to wear glasses. They did not choose to have a fetal alcohol spectrum disorder, and but it's also not due to bad parenting, bad environment. Also, people believe they're going to grow out of it. Wrong. Beep. It lasts a lifetime. People all say one episode of binge drinking can't cause fetal alcohol spectrum disorder. I've listened to videos of mothers who say that they did drink one time and binged at a party, and they have a child that has some problems. Depends on what happens. Other people say, low to moderate drinking can't cause it, or it only happens if the mother drank during the first trimester. And lastly, only those with an alcohol use disorder have a child with an FASD. Well, let's look at what we have here. We have several. We have fetal alcohol syndrome, and that's what most people think of. We have a neurobehavioral impairment. There's facial features There's a growth delay. There's structural brain damage. Well, we can have partial that has the neurobehavioral, the facial features, and notice that but you either have to have growth or structural. And then alcohol related, hey, you have to have this confirmed prenatal alcohol exposure. But now also in 2013, DSM-5 came out with a neurodevelopmental disorder associated with prenatal alcohol exposure. And there are 3 areas. There's this neurocognitive, where there's problems with thinking, memory, learning. There's self-regulation, the behavior, the sensory attention, and there's also these daily living. We have to see an onset before the age of 18, and there has to be a history of prenatal alcohol exposure. So what does that history mean? It means that there's 1 or more of these. So did the woman drink 6 or more drinks per week for more than 2 weeks? So that's regular drinking, 6 drinks, or 3 drinks in or more per occasion on 2 different times. That could be 2 parties. That means going to 2 parties and binge drinking. Also, then there's the social problems or evidence of alcohol from, the usual tests, documentation of alcohol exposure during or at birth using biomarkers, and the increased risk of drinking during pregnancy determined by a validated screening tool. And I think there's more articles out there about the different screening tools, expert and that can be used, and also the way that questions are asked instead of how much you drink, well, before pregnancy, how much alcohol did you consume, and different questions, the way they can be asked. Now, the majority of children have, they have learning behavioral functional problems, but you know what? It's an invisible disability. They don't have, excuse me, I guess I need more coffee. They don't have those facial features, and only 25% have an IQ below 70. There's a good chance that 1 in 20 in every classroom are affected with an FASD. So we have this FAS at the top, that fetal alcohol syndrome, and we can see that. But all below the iceberg, we have these other conditions. So how do we identify FAS? Well, there's a medical diagnosis. It's 86.0. There's 3 facial abnormalities. So we have short eye fissures. So you compare, we have this smooth fulcrum here and a thin upper lip. This is actually a picture of my son when he was actually at the orphanage in Russia, when I didn't know anything about FASD. He's also, he's going to be 30 in July, and he's still very short for his, for his stature. And, but, there's been no official confirmation. But anyways, there's a documentation of central nervous abnormalities or combination. There's a documentation of prenatal alcohol exposure helps, but if all 3 of those facial features are present, you don't need to document there doesn't have to be documentation. And it's usually present 8 months to 8 years. Now remember, my son's 30, so if you think about when he was born and during the 90s, people were not as interested in diagnosing, and saying, well, is this on the spectrum? Because what good is it going to do? He has a learning disability, and we're going to work with that. But remember, only those with the syndrome have those facial features. Now, how do you identify the others? Well, again, those full features are only required if you can't substantiate that the mother drank. Now now let's go to the NFASD. An early diagnosis before the age of 6 can reduce secondary characteristics. Although and I don't want to say it's difficult to get anyone to recognize it, even today, because my granddaughter is 7, and we started having her evaluated at school, and again, and the doctor, and I've talked about it, but there's nobody that will say, okay, I'm going to diagnose this. And I know her mother drank because my son confirmed it, and also the people who were living near her at the first few months of pregnancy would validate that she drank. So there's no simple test, because most individuals with fetal alcohol spectrum disorder, they look normal, they don't have facial features, it's invisible. And again, there's very few clinics will diagnosis, and again, it requires an admission of alcohol use. Now, you can get an accurate diagnosis if it's, medical, mental health professionals work together, and clinics. There are some clinics, especially, and there's several in North Carolina, and they include physical, occupational, and speech therapists. But let's think about that word neurobehavioral. So, and Diane Melvin from Facets talks about this, but it's a physical condition. It really is. Just like, if I hurt my leg, or, I have tape on my arm right now, hurt my arm. It's a physical condition because alcohol kills the brain cells. So it affects the structure and the function of the brain. So the behaviors are actually symptoms. They're not actually a disorder itself. So it's an invisible physical disability. So a physical disability, while I have one, well, first I was nearsighted, but then I had my eyes corrected, and now I'm farsighted, and now I need glasses to look close. So I have a physical disability, but it's not invisible. And then we have these behavioral symptoms, which create lots of problems because people don't understand that the underlying problem is really this invisible physical disability. Oh, and this is a picture of my son and my granddaughter together. So again, those symptoms, let's look at fetal alcohol spectrum disorder as this umbrella. And again, the behaviors are the symptoms of this physical disorder, the brain damage. So look at what we might have. We might have learning disabilities, attention deficit disorder, and there's more research coming out that show that, what percentage of children with fetal alcohol spectrum disorder actually have attention, are diagnosed then with attention hyperactivity disorder. There's mental health issues. And I just listened to a podcast the other day, a researcher talking about how they were doing brain studies and a special kind of imaging MRI, which possibly it could be the actual brain damage itself that causes a lot of the mental health issues. We have emotional behavior disorders, we have slow learners. So it's all these things, the processing pace, the executive functioning. So again, we need to reframe our thinking to say, oh, it's a physical disability. So instead of saying they just won't do that. I have to keep reminding my husband, when he gets so upset with the 30-year-old and he's like, well, he won't do this. I'm like, he can't. It's brain damage. Except he's pretty resistant to anybody helping him, which makes it more difficult. My second son, we actually manage his money and don't let him have access to all his funds at once, and keep account of things. But it helps shift the perception. The person's not the problem. They have a problem. So again, would you expect the same behavior of a 4-year-old as an 8-year-old? No, well, act your age, Would you expect the same behavior of a 17 as a 30-year-old? My son, my 30-year-old, my almost 30-year-old gets in trouble all the time because, he talks to all these girls on Facebook and then his girlfriend gets angry. That's like 17-year-old behavior. Shake my head. So let's look at the gaps. There's these huge gaps. So these are the kids where they can do one thing really well and another thing, and you go, oh my God, and you're pulling your hair out because even as adults, you're pulling your hair out because they can do something so well. So they have some real strengths, and their developmental age might be a lot lower. So again, we might have an 18-year-old whose developmental age is more like 9. The receptive language is more like 8. So even though they can talk like they understand things, and they could repeat it back to you, that doesn't mean that they can put it into action. So their expressive language can be very high. And that's what, again, my 30-year-old got in trouble all the time. People would say, well, the guy he worked for would give him directions and give him so many directions at once, and he'd get in trouble because he didn't do certain things. And guess what? It's like, well, he can joke. His expressive language is great. It doesn't mean his receptive language is working. So again, let's look at those behavioral symptoms. You have this underlying brain damage, you have the structure and the function, and you got to think about there are some strengths there too. But then there's the secondary character. Talk about a physical disability, all of a sudden I move my arm the wrong way. There's all those defensive behaviors. So we have to change the response in the environment. My son was a cutter. Now he tattoos. All right, so all these issues in young children. So if you're working in a capacity where you're working with families and you're looking at young children, we might have all these other things. We might have some attachment issues, irritability, tolerate change. I'll never forget this little boy I worked with. Oh my gosh. Because I was a resource teacher with kids with learning disabilities and emotional behavior disorders. And this one little boy, oh my, if there was a field trip and that things changed about lunch, woo, he just flew off the handle there. Couldn't adapt to change. They can be big eaters, lack of appetite. They can be sensitive to pain or not sensitive to pain. They don't know where, they can get in somebody's space. They can have fine motor issues. You're not part of this presentation, kitty cat. Don't walk across my screen. All these issues. So those are some things we want to look at, overall. And then we really want to look at their strengths. What do they do well? What do they like? What are their best qualities? Think about what are your funniest experiences. Now, I've been to a lot of IEP meetings in my life, and I don't think I've been to one IEP meeting that started with, these are the things your son does well. Not one. And now I'm starting to do IEP meetings with my granddaughter, and things are, at least the behavioral objectives are much better. But, so we got to identify the strengths in the family, the teachers, community. Always focus on the individual first. So what are some typical strengths? And Dan Dubosky always talks about, how they're friendly and likable. My son got in a lot of trouble when he was a teenager, but boy, he was really good with young children. And we would go to Florida to visit my parents, and he would love sitting around talking to some of the 80-year-old men, and they would talk about their experiences during World War II and all this, and he loved it, and they loved him. He was always really good with them. And he also has points of insight. Unfortunately, they don't always come at the right time, but he does have some really good points of insight, and he can compare things sometimes and just pull stuff out, and you don't realize it. They can be very caring and also hard worker, but you need to phrase instead of do this. You're like, boy, I'd really like your help. You know, do you think you can help me do that? So always when you're working with children or patients or adults, think about what are their strengths, and then how can those strengths lead to opportunities. You know, again, I was thinking if a student can work with Legos, could they work for an architect making design models? And my one son is 20. He'll be 29 at the end of this month. You know, and someone said, why is he doing Legos? And it's like, well, it's sort of therapy. But again, it's working that parts of the brain that probably need stimulating. Or can a young adult who watches YouTube, they could learn to fix lawnmowers or something. You can learn to fix about anything on YouTube. I was looking up YouTube to how to fix my sprinklers the other day. So let's think about the strengths and how that can lead to other opportunities. So if you have clients who seem resistant to a treatment program, think about their strengths and how we can turn it around to work with them. So again, what about we have this iceberg, and we talked about the iceberg that we only see this little bit of fetal alcohol syndrome, but there's another iceberg, and it's the iceberg of behaviors, because we can see kicking, yelling, mouthing off, slamming the doors. But what's really going on underneath? I need a break. I need love. I want a hug. I'm tired. I want to connect and I don't know how. I need some alone time. I'm overwhelmed. So there's all these things we see and how we can deal with them. So again, we misinterpret things and it causes problems. So somebody might not be compliant and we think that's willful. They're being willful and stubborn, but it could be they just don't totally understand the verbal directions. They don't understand their treatment plan. Oh. They make the same mistake over and over again. Again, that can be seen as manipulative. But it's because they can't link cause and effect. They can be late. They can be late to appointments. They can be seen as lazy. Oh, you're a poor parent. They don't care. But they can have problems with time and organization. Dan Dubosky told a story. I listened to one of his webinars last week. And because I'm always learning something new, and it always reminds me about things that I need to remember and dealing with the people in my life. Because I'll just make it personal here. I deal with two sons. And then we have the mother of my granddaughter and her husband. Okay, so my son and his new significant other. And then we have my other son and his ex-wife who has custody of the 3 grandchildren, and he has another girlfriend. So I'm dealing with this extended family here. And I'm watching them and I'm listening and I'm thinking, okay, how much of their history affects the way they do things. So Dan tells a story about someone who's always late. She was always late for appointments. So what she didn't figure in is she couldn't figure out that she had to figure in the time it took to get there. So if my appointment's at 3, she'd leave the house at 3. So what he did is he programmed her calendar in her phone to go off so that it would go off, ahead of time. Now, all of us know to do that. Well, not all of us, but most of us know to do that. And so her therapist had to do that for her. Sometimes I just misjudge time and think I can do things faster than I do. For example, another example, in school, out-of-seat behavior can be seen as willful and following directions, but it could be sensory integration. Maybe it's too loud. Maybe it's too quiet. you know, so we don't know. I think about the time my son got big trouble and then was suspended and got sent to a special school because he had a substitute, and the substitute was letting everybody run around the room and do things. And of course, kids were flipping pencils, and he flipped a pencil. And of course, what happened to his pencil? It went and stuck somebody, you know. So of course, he ended up in big trouble because, you know, supposedly he was trying to stab somebody with a pencil. But again, it was that whole sensory integration of all the stuff's going on. So I'm just going to take part in it. So here's a good example. You know, of a test here. Is this misunderstanding? Is somebody lazy or something else? In which battle did Napoleon die? His last one. You know, I love these answers. I wouldn't have given it. I always say creative thinking. You know, where was the Declaration signed? At the bottom of the page. I'm sure the teacher probably thought that the person was just being really cheeky. What state does the Ravi live for? Oh boy, now I'm going to have two cats here that are going to maybe cry. It's in its liquid state, you know? And so technically these answers are correct. They're just not the answers the teacher wanted. So again, we've got brain damage. It causes lots of problems. Now, I'm not going to go into the study of the brain, but you look at all these parts of the brain. The frontal lobe has all the memory, emotions, decision-making, you know, all that executive functioning. If the frontal lobe is damaged. Also, the frontal lobe doesn't fully develop until our mid-20s. So think about this. You've got damage and you have, you know, this delayed, fully functioning frontal lobe. You know, the cerebellum is our motor skills. The hippocampus is long-term memory. You know, which it can be another strength. I mean, some people affected with prenatal alcohol exposure have wonderful long-term memory for things, but then they don't have that short-term memory for their multiplication facts. Now the basal ganglia is all those voluntary movements, the perception of time, working towards your goals. I mean, think about switching gears. And then the corpus callosum, that helps link the left and the right hemisphere. That means I might feel this way, but outside I don't look this way. When my son got arrested when he was 13, and he was sitting, you know, on the bench, and the lawyer thought, well, he's having fun. He's just sitting there joking with his friend. Again, that didn't necessarily mean what was going on in his brain and how he felt. So his expression of things, it wasn't necessarily connecting the logic to those impulses. That gets him in trouble a lot. So let's talk specifically about some problems and then what are the solutions. So we have lots of behavior and emotional problems. There's that damage to the amygdala. They don't have control over their emotions. They act oppositional, they have outbursts, they don't show impulse control, they keep breaking the rules. They lie, they fill in the truth. They definitely don't respond to rewards and consequences because they don't link those. So here's the cause and then here's the consequence. Well, it's like two different things. They can feel like they're powerless, which then leads to a lot of, you know, mental health issues and anxiety. They can't always read facial expressions. Dan Dubosky said that he actually stood in front of a mirror with his son and helped him, practice facial expressions because his son would have the same facial expression no matter what was going on. So he had him doing that. They also sometimes have problems with physical boundaries, you know, touching, affection. So what are some solutions? Well, if we have somebody who doesn't understand the consequences, normally we say take something away. But they don't learn by experience the consequences of their behavior. So Dan always talks about how they told him to take away karate from his son if he didn't do his homework. Well, you know, he still didn't do his homework and he never did karate again. And that would be like taking guitar away from my son when he was in his teens. You know, again, he would have never done that again. It's like so big deal. We can't always use natural consequences, and we have to make the consequence short, you know, a one day. We have to use positive reinforcement immediately. Again, there's lots of studies that talk about for every time you say no, you've got to say yes 5 times. You know, depending on the individual, you've got to think about use of timeout, ignoring behavior, redirecting it, reward for completion of tasks. You know, timeout to some kids means you are, you know, ignoring me and I'm not valuable. So sometimes timeout is not the way to go. Tough love doesn't always work with a teenager because they don't always make wise choices. What's the solution if they lie? We call it confabulation, because they try to fill in the blanks. Again, remember, there's that problem with memory. So I have this little bit of memory, and I have this little bit of memory, and I have this little bit of memory. Well, let me see what I'm going to do to fill in the blanks. It's like we're reading Ginny B. Jones now. My granddaughter loves Ginny B. Jones. And Ginny B. will get in a situation, and the teacher will say, okay, Ginny B., what's the story? And Ginny will say, nah, so I thought about it. I thought about the best story. You know, so again, they confabulate to fill in these blanks. And because they have problems with time, they end up filling in a blank from here to here, and who knows, you know, there was something else that happened in between. Or they say something happened and it sounds like it was last week, but it was really like 2 years ago. Again, they put together different places, times. So you need to verify the person's story from credible sources and not always peers. So when my son got in trouble in middle school, they would have him write, well, here's a boy with a learning disability, and all his friends had learning disabilities. And so they have 3 boys that write these sentences that you can hardly read the sentences because they can't spell, about what happened in the incident. And then they ask these girls to, you know, like what happened in the incident. They write a page and a half. And so again, is that a credible source? You know, so again, how they feel, it might look like lying, but again, so confabulation is that coping skill. So they're trying to jump ahead and think, well, what do I need to say here to get accepted? With my one son, you know, you can ask him about the 3rd time you get the right answer. Now you go, what really happened here? So again, related to that, they have problems with social emotional because they're so easily manipulated, and they give in to peer pressure because they want to be accepted. So they just go, oh yeah, go do that, and they go do it. They might not have any friends, or the friends they have are kind of on the deviant side. And my son used to always do this. Well, my friend so-and-so, and it's like, what's his name? I don't know, you know. They're at high risk for criminal behavior. They have difficulty in social situations. They can have a lack of fear, or, you know, so they can be friendly. They can walk off with strangers. They can steal, take other things, and not because it's like, ooh, you know, I'm going to steal it, because, oh, that person left it there, so it must be for the taking. You know, they want to be well-liked. They want to be part of a group. When they get older, they might make inappropriate advances. And one mother talked about how her son was always taking her purse and taking stuff, and it was like, to him, it wasn't that it was like, oh, I'm stealing. It was because he thought, well, it's just sitting here. It's not her stuff anymore. So what are some solutions? We have to provide skills training and model. We got to keep them actively involved. We got to work on those strengths. Again, find those strengths. Help foster relationships with positive peers, positive mentors. Mentors that understand that it's not willful and purposeful. My son had a mentor, but unfortunately his mentor thought that everything he did was willful and purposeful. They do better in a one-on-one. they often do better with adults than peers. So again, talk about proximity and how just because it's close to you doesn't mean it's yours. And think about whether their behavior is to get a response. Even at 29 and 30, they're still doing stuff that get a response. Ooh, I let the cat out. Ooh, the cat left. No, the cat didn't. They're trying to get a response from me. But again, I can't be good, so I'm good at being bad, so let me keep being bad. Let that sink in for a minute. I'm good at being bad, so I'm keep on being bad. So what are these solutions? So if they don't follow the rules, got to do lots of repetition and reinforcement. Just like if you had somebody with traumatic brain injury, we've got to keep the rules simple. We got to be positive. Just because they explain the rule doesn't mean they can repeat it. So again, as Dan would say, they can talk the talk, but not walk the walk. So they need to act it out. See if you can give them a not example of the rule. Provide reasons for the rules. And keep it positive too. Because we don't want rules to be, don't do this, don't do this, don't do this. Provide some flexibility, give immediate rewards. Again, we can't always change the individual. We need to change the environment to make it easier for them to follow the rules. That was like we make it easy for people to follow the rules about restrooms. We have arrows and signs. What's the solution for outbursts? We look for signs of stress and we try to diffuse it before. So if I'm distractible and agitated, we can provide a quiet environment to chill out. We can ask if they need help, provide second chances, check our expectations. We want to be calm, consistent. We need continued structure and support over time. So even with adults, we have to be consistent and calm, and we have to continue the structure and support over time. Now, they also have problems with sensory processing. Remember, this is the hypothalamus with the sensory, the appetite, emotions, temperature, pain. They can have meltdowns from sensory, just too much sound, sights, tastes, textures. Like I said, I had lots of mornings where we've had a meltdown about clothes. We can get clothes out the night before, but not necessarily they don't feel right in the morning. Not a problem. Lots of times a meltdown can be mistaken for a tantrum. We have meltdowns a lot over being too hungry or too tired. Of course, when I was growing up, the worst thing my mother would say, "You're tired, go to bed." I couldn't stand that. So I know that my granddaughter hates that. You're acting like you're crabby because you're tired. I know she hates that because I hated it. They can be fearful of crowds. They can be fearful of climbing, or they can be totally oh, nothing's going to happen to me. I'm on the top ring in the playground and I'm going to jump off. The irritations due to touch and clothing. My granddaughter wears her socks inside out because those strings can be irritating. Adults with sensory disorders, a lot of times sensory disorders, you cope with drugs or alcohol. I'm sure my 30-year-old does that. He copes. Again, they can have a high or low threshold for pain. They can be short-tempered, high-strung. I'm sorry, I'm watching. I got distracted for a minute. Talk about distracted. So what are some solutions for sensory? Tagless shirts, socks inside out, soft toothbrushes. 2 things my granddaughter hates to do. Brush her hair, brush her teeth. We got her hair cut yesterday, and she brushed her hair this morning. She loved it. We want to reduce the visual clutter, reduce the auditory stimuli. I know a parent told me a story about his son. His teachers, he kept saying, "I can't do this test. I can't do this test." He kept saying, "I hear a hum." And apparently his teacher's radio, even though it was off, it was giving off a and that was irritating him. Visual handouts, you want consistent size. I did another presentation where the slides, the font was all messed up, so that did not follow that rule at all. You got to learn to retrain the senses. So they do recommend like art therapy, peer support groups. Again, peer support is important. What are some problems to help with the problems with attention? That's again that damage to the frontal lobe, self-regulation, alertness, coming to attention, staying on task for long periods of time, heavy prenatal alcohol exposure. Kids have problems with focused attention and then shifting attention. And that's always a huge issue. It was huge issues for my son. It's a huge issue for my granddaughter. So if she's in doing something, it's like, I'm doing this right now. So we have to work on shifting attention. When the boys were little, we'd always set a timer. When the timer goes off, it's time to do whatever, So we have to work on maintaining. They can't maintain sustained auditory attention. So the one good thing about this being recorded is if you have problems sustaining auditory attention, then you can always pause it and come back to it later. What are some solutions? Again, we want to reduce the load. We can set alarms, timers, reminders. We want to work on one goal at a time. We can use texting. Like I said, the therapist who set the alarm for the person, or we can send text to remind people, because there's all those automatic ways you can send texts out. We want to reduce all that clutter and noise. Again, individuals may hear or process every third word of normal speech. So they have this inability to sustain their auditory attention because they're focusing. Rick Lavoie, who I listened to years ago for learning disabilities, talks about how, one way is to, like for kids who have problems in school with answering questions, because they're always thinking about the question before, the teacher would stand in front of that child's desk, and then that child knew that the teacher was going to ask a question for them, and again, that would kind of be a cue. And I talked about they have problems with verbal reception. Their expressive ability is much more advanced than their receptive skills or their ability to produce written products. So a lot of times oral testing might be important. They can't process several directions at once. They say they know what to do, but they can't show you. So here's this little test. It says put each word in alphabetical order. Put the words in alphabetical order. Well, they did. They took each word and put it in alphabetical order. So again, understanding, being specific about what you want them to do. Take this list of words and put it in alphabetical order. Described as a 10-second person in a 1-second world. So what are some things we can do? Again, solutions. Be specific. They'll do what they're told. Again, back to those Junie B. Jones books, we're reading the book Monkey Business, and her grandmother came in and said, oh, your mother had her little baby boy, and he's the cutest little monkey you ever saw. Well, Junie went to school and told everybody that her baby boy was not only a baby boy, but he was a baby monkey. Got her in a bunch of trouble. But we can't use sarcasm, joking, similes, metaphors, proverbs. With my granddaughter, every time we ride in the car, we talk about things, and I try to explain stuff and the use of different words. Consider the misinterpretations. Fall flat on your face, pick up the floor, bite your tongue, bend your ear, and allow extra response time. I always said that for my son. I'd ask him, my older one, I'd ask him a question, and then he would, and I couldn't expect an answer right then. He really needed think time. He needed the think time. So, problems with executive functioning and working memory. So, storage and retrieval. Let's think about this. So you have a filing cabinet and you have things in certain places, and you go to get them and they're there. But what happens if today the filing cabinet's locked and you can't get it. So they have that inability to access the information there all the time. They can't keep track of multiple plans. So if you have a therapy plan, you've got to be careful to make sure that it's very simple and specific, and there's certain goals at one time. Even if they've memorized something, they can't always put it in action. They can't apply knowledge to new situations. So if I say, lock the door when you leave, you lock the door, and then, you might lock somebody out. It's not lock the door. It's lock the door if nobody else is home. You can't deal with those multi-step. So what are some solutions? Well, we might even have to become an external brain for that person. We have to reduce their cognitive load and create strategies together. Like what might be a strategy to do, especially with, young adults, what are some strategies we can work on? Use calendars, apps on the phones. I'm still surprised that everybody uses their phone. They can look up stuff and watch TikTok and, and all those things, but to get their calendar out and to put a date on it and to put it so that it reminds them, I don't understand why they can't do that. Hand me your phone and I'll do it for you. Provide one direction at a time. Jot notes on 3x5 cards. I had a student once who would always, he had his little 3x5 cards. He'd pull them out and he had different things on them. Provide a checklist. For young children, you can provide a little checklist. Put puzzle pieces together. And, that's visual task analysis charts. I was trying to think where I was going to tell the story about the external brain, and the cognitive load, because we can only do one cognitive task at a time. We can do many automatic tasks. And so when we learn something, when we're first learning it, it's cognitive. And then it eventually becomes automatic. So driving for adults, after we've driven for a number of years, it's much more of an automatic task, especially if the weather's nice and the roads aren't busy and things like that. But all of a sudden you're driving, it's rush hour traffic and it's raining. Now driving becomes a cognitive task. So you can't sit there and have a long conversation with your kids at the same time. So you have to tell them, hey kids, time to be quiet. Very nicely, right? And because you can only do one automatic task, one cognitive task at a time. So that's why we have to reduce the cognitive load. They have this impaired number sense. That's another problem. Following directions to put up the tent. We have, or who knows what they were doing with this device, but they weren't doing what they were supposed to. They have problems telling time, money, measurement. Like I said, calendar dates. Again, that difficulty of time of retelling events. So if we have problems with a timeline, we don't always get things right, and then people think we're lying. Again, that's that planning, mental manipulation in your head. I'm always doing mental manipulation in my head about what I have to do and when I can do it, and lifelong skills, and making payments, keeping dates. So as they get older, they might have to find a significant other that understands that and helps them manage money. Hopefully they will, and they won't have a significant other that just says, okay, you do it yourself. It's your responsibility, because they can't. So what are some solutions? Again, here's another one, interpretation. Make sure that language isn't the problem. Circle the smallest number. Well, the smallest number is 1, 2, 3. So is language the problem there? Following directions. Make counting a physical. Young children make counting a physical activity. One mother said that teaching time by association of different things, like when I eat lunch. Provide support for shopping. Like a mother said that she had her daughter always go with a peer when she was a teenager to help with shopping. Help with expenses, or have a coach. They have problems with abstract concepts, a slow processing rate. Again, I talked about that earlier. They can't predict what might happen. Difficulty making links, forming associations, literal concrete thinking. Again, here's this automatic tasks remain cognitive. Those cerebellum controls those automatic tasks, and they end up staying automatic tasks. This is pictures from when I did the top of the ladder, the bottom of the ladder. So those concept things. So again, we need to help them to learn concepts. We can role play. We can do a task analysis of a skill. Even with adults, think about the skills they have to do maybe to complete their therapy plan. Let's do a task analysis of what you have to do to get to that goal. You can provide examples and non-examples of kind of behavior they need. Provide guided practice, a lot of modeling. Make sure that they understand the directions and they can do that academic or life task. I like this little thing I saw, I earn money at home by, and it said I don't because I'm a freeloader. Now, what if you're working with parents or caregivers of a child who has fetal alcohol spectrum and who was prenatally exposed by alcohol? I really like that term better. But us parents, we lack support. I don't know how many times I've been a bad parent by a judge, by a therapist, told I would have been a great parent for normal children. What's normal? Irma Bombeck used to say that normal was a setting on your wash machine. And I don't even think it is now. But we lack support. We lack credibility. We need a non-judgmental and a confidential outlet. So if you're working with a mom and they're talking about craziness and, we need this confidential outlet. I mean, even now I need an outlet. And here I am giving a workshop. There's several Facebook groups that are private, so I can go and I can post stuff. Because I need somebody that's going to be non-judgmental about the things I say and just what I'm going through. Again, you have to think that maybe the parent was also affected by prenatal alcohol exposure. Again, many of these parents deal with sexual, promiscuity, all these other things. Difficulty with boundaries. I love this. This is from the, I'll put this on because it's smaller, but if parenting is running in a sprint, then parenting a special needs child is running a marathon, but parenting a child with a fetal alcohol spectrum disorder is like running with the bulls, and it is. You have to keep one step ahead all the time. Everyone says, find out what they're motivated by, find out, that might work 2 times, and then you got to find something else. This is families affected by fetal alcohol spectrum disorder. So we have the same issues. Again, in adulthood, we might end up with residential placement, economic problems, depression, suicide, pregnancy, fathering a child. Even though my older son did get married, his first child was born before they got married. And she had just turned 18. They have increased expectations as they get older because people think, well, you're 30 years old. You should be able to do this. They can withdraw. They can isolate. They have unpredictable behavior too. And other people expect more. Adults, adults showing physical or cognitive effects, have difficulty with adaptive function. Now, interesting enough, males with cognitive effects can be the most strongly affected, probably because of the way we see males in our society. You know, they're supposed to be the caretakers. Even now, people think, you know, supposed, you know, I know, you know, that's one of the reasons, you know, my son and daughter-in-law divorced is because, you know, she saw him as being able to take care of things that he really couldn't cognitively. And again, they can be those who have all these diagnoses. And my second son has every single one of them. He has been diagnosed. I'm looking at this. As you can read it, cognitive, depressive, personality, mixed borderline. Yes, he has personality disorder, NOS. I mean, all those. He has collected every single one of these diagnoses from all the treatment facilities that he has been to and schools and placements. I do want to say that although his vice is drinking alcohol, he drinks, you know, but he's also diabetic, so that's a problem there. But I do want to say he's working in a little restaurant, and he does very well. He's like the main cook, and it's kind of a combination fast food, takeouts, eat in, and he does very well in that. And you know, the boss really relies on him a lot. So he does have that strength. I mean, cooking is a big strength of his, and he has found kind of his niche. Fetal alcohol can also cause addiction relapse. So, you know, we have to address if you suffer guilt from drinking while pregnant, then you can have a relapse. Again, if you have a child who's unidentified as having a fetal alcohol spectrum disorder, oh, good grief. The behavior, you know, you're going to have a relapse because you might go be crazy, you know. And again, the woman itself might have fetal alcohol and a risk for relapse. What if you have a client or a parent with fetal alcohol spectrum disorder? They might miss appointments. They don't plan. They don't understand their treatment protocols. And I've mentioned all this before. They can't follow through in multiple directions. They might end up repeating behaviors. Here's a good one. My granddaughter's 7. She has 4 older siblings that are step siblings. My son is the only that one. That's 1 father, 2 fathers, 3 fathers. Then she has a sister who's younger than she is, has another father, and then her mother has married, and she is now expecting another child. And her husband has a has a daughter. So essentially now she has 8 children. And right now, none of them live with her. So again, we have repeated multiple pregnancies. A lot of times they have children removed from their care. The children are in foster care. 70% of children in foster care were prenatally exposed to alcohol. There are 2, the choices, the CDC funded program for non-pregnant women at risk. There's also the Parent-Child Assistant Program, which is a 3-year case management model. There's some other resources. What are the risks? Well, you know, we've kind of woven all that in. There's unemployment, your loss of your family, loss of parental rights, homelessness, jail. 40 to 70% of those in jail are prenatally exposed to alcohol. Premature death, you know, the mean age of death is 34. There's a high risk of diabetes, heart disease, increased substance abuse. Again, the wrong treatment or intervention used. You know, talk therapy doesn't always work because they have problems with that receptive language. And what about the family? You know, loss of friends and family. Increased substance abuse, premature death, financial strain, emotional. There's a lot of emotional stress. And I would say that I probably have very few friends. My husband and I feel really isolated sometimes. And my husband and I are both retired, so we feel really kind of stuck a lot of times. These are all things that can help reduce all those complications. We need a stable home, an early diagnosis, a recognized disability. Now, interestingly enough, if you have a diagnosis of FAS, there's actually less complications because it's not invisible. And so people are more likely to do some things. Dan Dubosky talked about a woman had a number of adopted children, and she had one who was recognized as FAS, and he was in a band and did very well. He was way in his 30s. And then she had another little girl who was just on the spectrum, and that child did not do as well as in adulthood, had a lot more problems. Also, if they have a good quality of home from the ages of 8 to 12, and their basic needs are met for 13% of their life. So what are some overall strategies? Again, be consistent. You got to simplify and structure the environment. Use lots of repetition, rephrasing, provide one direction, a rule at a time. I always got to remember that. I mean, I need to remember the slide and put it up on my wall. Listen when they say they can't do something, but they're trying. They get frustrated. My son once told a friend of mine who's a resource teacher, he said, the one thing I wish my teachers knew is that I really couldn't do some things, and they thought I just didn't try. Remember, you want to de-stress, because stress creates cortisol, and then, there we go. You're bringing a match to the fireworks factory. So we got to let things de-stress, calm down, and then we can talk and deal with things. What's a take home? We can't change the behavior of the damaged brain. It's damaged. I can wear my glasses to help the fact that I can't see, but I can't just change my eyes. But we can change our approach or environment, which means I can put my glasses on when I need to see. We need to consider their point of view as they learn and see things differently. Remember, they don't choose to have a fetal alcohol spectrum disorder. They didn't choose this, and they have to live with it. Here's some resources and guides, and you will get this handout. And here are also now, unfortunately, we have a kitten in this house who wants to be part of this presentation. The Canadian resources and guides, they have some really good guides for work, tips for employment, tips for coaches, support. So there's a lot of good resources there from Saskatchewan. Again, this is not a problem in just the United States. It's not a South Carolina problem. This is a problem all over the world. There are organizations in Canada, Australia, New Zealand, England that are really trying to work on this, of saying no alcohol for 9 months. Again, you can go to our website, and there's a number of videos, other videos you can watch. There's a number of videos by Dan Dubosky on there, and some other things that are available. There's resources and these handouts. Just remember, 9 months, no alcohol. I'm worth the wait. If we're not sure about the effects of alcohol, if we're not totally sure, then 9 months is worth the wait for no risk. For more information, you can contact any one of the 4 of us. There's my email. If you have any questions about this presentation, questions that came up, you want more information, here's my email, drwissick@gmail.com. Just remember, there's no safe amount, no safe time, and no safe kind. Alcohol causes more damage than any other substance, and it lasts a lifetime. So I'm worth the wait. Again, why take the risk? So I'm going to share my GoToMeeting screen.